Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Welcome, everyone, to this episode of Thinking Thoracic. My name is Jane Yanagawa, and I will be the host for this episode. And we are so lucky to have with us our special guest today, Stephanie Worrell. She is an amazing thoracic surgeon. She is also a section chief of thoracic surgery at the University of Arizona, an associate professor of surgery, and an associate program director for general surgery. We will be talking today about the topic of esophageal perforation. Hi, Stephanie.
Hi, so good to be here with you.
Well, we are going to hop in pretty soon to talk about esophageal perforations, but actually I was wondering, could you also just tell us sort of how you got interested in the esophagus? Yeah, what drew your interest to esophageal disease? You know, you have such expertise. You've been invited, guest speaker to so many different conferences. I've been lucky to hear so many of your talks that are always like super up to date, easy to understand, and really comprehensive. What started your interest in esophageal disease?
Thank you so much for that introduction. Very kind of you. Yeah, actually, it started very early. So, I was when I was a medical student, one of my mentors, his name was Sumit Middle. He had actually trained under Tom DeMeester and did a lot of esophageal work. And I thought, I saw my first esophagectomy and just thought it was the most amazing thing I'd ever seen. And so I followed in his footsteps and went to USC, where I got exposed to a lot of esophagus with Tom and then Steve DeMeester, Jeff Hagan, Dano, and they were really great mentors. I went into their esophageal manometry lab during my research time. So I spent 2 years doing just esophageal manometry. So understanding like the physiology of the esophagus. And, since then I've just had a passion for kind of all things esophagus.
So, talking about today, a very important topic in our field, something that we all encounter, something that is tested on. In terms of esophageal perforation, there actually has been a lot of changes in the management of this disease recently. And I was wondering if you could sort of talk about endoscopic approaches to managing esophageal perforations. What do you think are good cases for an endoscopic approach? Of the different endoscopic approaches, how do you pick and choose, and maybe giving the listeners an idea of what the pros and cons are, as well as sort of the post-op management and post-op recovery from the different types of endoscopic approaches.
Yeah. Yeah. A lot really has changed fairly recently too. So, when I was in fellowship, even we did all of them open. We would repair them and inevitably they would probably break down and people were in the hospital for a long time. So I think first off, stents really gained a lot of popularity, but stents are sort of tricky and they don't really address the problem. They just kind of cover up the problem. And sometimes you can get like a contained abscess behind that. But I think now with the advent of endoscopic vacuum therapy, I honestly, I don't feel like I'm repairing primarily esophageal perforations at all anymore. So I will often do a VATS washout, put drains by the esophagus. I think, you really do have to clean out the chest most of the time. Sometimes with a perforation, though, that mediastinal pleural can sort of be intact. And if it is intact, you can actually still clean it out by just using a vac. So what I mean is you put the endoscopic vac sponge on the end of an NG tube, you take that down to the area of the perforation, and then you connect that to the suction. I think this is a really good approach for a lot of different variety of esophageal perforations, as long as the patient, is stable enough to spend some time in the operating room. It isn't, unstable. You're not just trying to get out of a quick kind of disaster scenario. So I think it's good for like iatrogenic perforations or even post-surgical, post-esophagectomy, like leaks that happen that are small. Maybe you already have a drain from your esophagectomy itself, and then just putting like a vac on the other side. You can also pair that with a stent. So they actually make a device in Europe that isn't available in the United States yet, but it is actually a vac around a stent. And so you can put this in and you can keep suctioning on it while there's a stent in place so people can keep eating and even go home. I think one of the problems with endoscopic vacs is that you do have to change them every 3 to 5 days. So that does mean going back to the operating room every couple of days to change them out. But I think when they do work or when they work very well, kind of create that granulation tissue like we're used to seeing for general surgery in the abdomen when you have like an abdominal incision that's like infected and won't close.
So essentially, they have an NG tube in order to apply the suction to that area. But you mentioned that they could come back to the OR. Could they go home with it and then come back every 3 days, or would they be expected to stay in the hospital?
So I haven't ever sent anybody home for like that short of a period of time, but I mean, in theory, you could because it's often they're fairly stable, like a stent patient where they're stented, so they're controlled. And if you have like a J tube in or some other form of nutrition, then I think reasonably you could send them home and bring them back in 5 days. They could manage that kind of home, coming in as outpatient, do that. Totally doable. I think that was the theory behind the vac stent one because you can leave that one in more like a week. So bringing someone back, every week is pretty, is usually pretty manageable. But yeah, I think it's a good idea. I think that's what we're all hoping for is to get people out of the hospital, just not them stuck in the hospital for weeks on end.
Right. What about for the nutrition side? Because everyone used to get a G tube and a J tube at the time of the surgery and things like that. What do these patients do for nutrition?
Yeah. So I am still often I'm putting J tubes in some of these patients. So I think if you have a real small perforation, I may even just stent them so they can eat and go home. This is more like that, a little larger, like maybe more than 2 centimeters. Maybe it's not like something that looks like it's going to heal quickly. Then I'm going to vac them. And probably, I had tried to put like a Dopphoff past one. That doesn't always work very well. Kind of suctions up the tube feeds. So it kind of can make a disaster. But I think putting in so I think I do put in, not infrequently put in a feeding tube in addition.
I think it's really interesting how you were saying also that you usually combine, doing an endoscopic approach with still like a washout or something to clean out the mediastinum. And I'm sure in a lot of the cases, maybe the perforation's been there for a couple days and you have to decorticate to make sure the lung re-expands and all that. Which means that even though it's endoscopic, it doesn't mean that it's a non-surgical treatment, right? Because then you still had the surgery for the chest portion and then potentially the J tube and things like that. So it makes a lot of sense for thoracic surgeons to be experts at these kinds of procedures too. There must still be some situations where you would prefer or feel that maybe a surgery was more appropriate, right? Can you sort of describe a situation where you might prefer to do a surgical repair?
Yeah. So I think there's very few where I'm thinking of like primary surgical repair. The people that I'm taking like for surgery, not thinking about endoscopic, are usually really sick and I'm diverting them. Like I think maybe they have or if they have like a really big perforation that I just don't think is ever gonna, like, is this an esophagus worth saving? That's one of the questions I always tell my fellow, like, is this an esophagus we should save? And if so, like, can we save it? I think a primary repair does much better than a vac. The esophagus is so tenuous and like you don't often get a good, even like putting a muscle flap on it, those tend to, I don't know, they just tend to fail quite frequently. So, I think, I've definitely done the where I've tried to vac them for a couple of days and that failed, and then I switched to a esophagectomy. But so in my mind, I'm thinking like endoscopic approach versus spit fistula, which is like two dramatic sides of the pendulum. But I think that's really the majority of the perforations. Those are the two things I'm thinking.
Are there limitations, like anatomic limitations for the endoscopic approaches? For example, like a cervical esophageal perforation?
Yeah, you can definitely do a cervical one. Sometimes they're pretty high and like the patient can feel it in the back of their throat, just like if you have a try to put a stent up high and it really bugs them. So I've done that on occasion, but cervical perfs, often just heal up on their own if you just open up the neck, and that's fairly minimally invasive. So I think if it's not too much contamination, I still favor just doing like an open drainage of the like it just yeah.
Do you have any interesting stories to share of any experiences with esophageal perforations and complex repairs?
Yeah. I think, as everyone's advancing in the field, there's the esophagus sits in like a very tenuous area, right? So I think with more like an EP procedures and even vascular stents, like I've seen the esophagus, if it perforates, can erode into like the aorta or the opposite direction, where if you have like a thermal burn to the heart, it can erode into the esophagus. I think those are always really challenging scenarios for thoracic surgeons, but also why I think we should be relying on ourselves to know all the techniques and not relying on GI to do a lot of the stuff around perforations. I think we have a better handle of all the surrounding anatomy. Yeah, I think but the number of esophageal atrial fistulas I've seen has definitely increased. Those are probably when you asked, about like a primary repair, that's a time I'm not gonna put a stent or an endo back there, that I'm gonna try to separate it from that. So try to separate the 2 structures. I always get my cardiac surgeon involved because I'm not gonna do that one by myself. It's nice to have more team members around. And then yeah, I try to repair them and then put like a nice big bulky muscle flap between the 2 structures so they're not touching. But sometimes if the field's been I think the tricky one is, recently I had a lady that had esophageal cancer that had undergone chemoradiation, and the tumor had actually eroded into the aorta. That scenario, it's like radiated tissue is not really an esophagus worth saving. That scenario, I'm just cutting it out and getting it completely away from the aorta. And then that the aorta was able to be stented, which was nice. But then she has a spit fistula and a stented aorta. So
I guess sort of on a related topic then for tracheoesophageal fistulas, you probably can't use the vac for those cases, right? Or could you also do the suction even though there's air on the other side?
I, I don't think that I would not advise that. It's a good question. In general, yeah, I think that would probably cause more problems as far as like the airway. That is an interesting scenario. I'm sure someone's attempted that, but I would not be bold enough to attempt that.
And like you were saying, some of these cases are really complex, and we work closely with our colleagues in other disciplines. And I'm sure there are people out there where the esophageal perforation might be a consult that goes to a thoracic surgeon or not. But it'd be great if we could also work with interventional GI doctors who might do similar procedures. But like you pointed out, a lot of the management or sort of the optimal management could be an endoscopic thing, but also include surgical. In general, though, for people who are either in training now or already out there practicing, but they'd like to learn how to either do themselves or be more familiar with some of these endoscopic techniques, do you have any advice on ways to learn that?
Yeah, I think, there's some great avenues through thoracic surgery scholarships. So there's a scholarship through the STS, through the Carolyn Reed scholarship. I did that one and I actually went out and learned more and just like oral endoscopic myotomy from the group in Oregon. I think Natalie Louie did the same thing. There's a scholarship through Western Thoracic as well. So yeah, I think going out, observing. There are some hands-on courses. So the Oregon group does have a hands-on course for POEM. I don't know of any hands-on courses for perforations, but just learning endoscopic techniques, I think, especially while in training, is important. And like you mentioned too, like you're right, like collaborating with GI, there are all these new techniques coming out as far as like endoscopic suturing and different like clips and stuff that they get a lot of experience with, particularly for, like even colorectal stuff or all the other stuff they do outside of the esophagus. So they definitely have a skill set that, sometimes it's nice to get them on board to help out, even if you want to do all of your own endoscopic stuff. I've definitely asked them for help with like tricky stent placements and like curing them in place because of some of that endoscopic suturing stuff that they have a little bit more experience with on a regular basis.
Well, thank you so much for joining us and giving us your expertise on this really important topic. And yeah, I hope that the listeners learned a lot. And I guess in general, it's a changing field. And I think, like you were saying, the multidisciplinary interactions that we could be having would probably be beneficial for everybody in every specialty.
Yeah, agree, definitely. So yeah, thanks for having me on your podcast.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.